friends, this is Riddhi Joshi and today I'm going to talk about wrist joint physiotherapy management. First, we are going to see management for carpal tunnel syndrome. Patient presentation in carpal tunnel syndrome. First, sensory problem. In a patient with a carpal tunnel syndrome, they may have pain on the radial side of the wrist, especially that will aggravate at night time. Pain and numbness on the median nerve distribution. Sensory is intact in palm area, but there is decreased 2-point discrimination in thumb and index finger. Positive TNS lines. Motor problem. Impaired functional task and repetitive activities that may increase pain. Patient may feel thinner muscle atrophy and they may feel atrophy of lumbrical second and third digit and lumbricals. Impaired pad to pad, tip to tip, tip to pad grip, and this is impaired. So if they are holding some objects like hammer, so that may affect their grip. There will be decrease in range of motion of the wrist, and metacarpophalangeal joint range of motion is also decreased, especially thumb, second and third digits. Decrease opposition due to involvement of adductor pollicis extensibility, and that is also decreased. Let's learn non-operative management for carpal tunnel syndrome. First, if we are applying the immobilization, apply splint during painful activities and night time. Keep splint in neutral position or 15-degree extension of MCP and IP joint should be free. To control edema, apply ice and elevation of your hand. We have to, as a physiotherapist, we have to educate the patient. So what will we educate them? We have to tell them they should avoid pain provocating repetitive activities if they are doing hammering or if they are doing knitting. So they have to avoid that kind of activities for some period, especially which is aggravating their pain during wrist flexion and vibratory machines. They have to keep their hand in neutral position while activity in daily living. For example, if you are a computer user, so you have to keep your wrist in a neutral position while using the mouse, because if a patient is doing flexion or extension activities with that wrist, that may aggravate their symptoms. Avoid forceful gripping and pinching activities. Regularly check sensation of your hand. Let's learn carpal tunnel syndrome management continuation. If we are doing mobilization, we have to apply mobilization according to their restricted pattern. Exercise, they have to do median nerve gliding, tendon gliding exercise, flexor digitorum profundus or flexor digitorum superficialis. Multi-angle isometrics of hand and wrist, functional dexterity exercise, and we have to give them ergonomic advice. Now we are going to see why we are doing median nerve gliding exercise in carpal tunnel syndrome. As we all know that in carpal tunnel syndrome, especially we have inflammation in the carpal tunnel that may cause compression of our median nerve, so that median nerve is get stuck in surrounding tissue. If we are doing nerve gliding exercise, so this nerve gliding exercise that will improve the movement of our nerve, and that, like for example, if we are doing hand and finger position, so for example, we have to straight the finger first in fist, then we have to straight the wrist bent backward, and thumb should be move out, means thumb should be abduction, and forearm rotated in palm up position, and finally gently we can apply stretch to our thumb using our opposite hand. So this will help for median nerve gliding. Let's learn tendon gliding exercise. But first of all, we have to know that why we are doing this tendon gliding exercise. In carpal tunnel syndrome, we have pain that is limiting our functional range of motion. So that is affecting our day-to-day activity and activity in daily living. So if we are doing this tendon gliding exercise in pain-free range of motion, so your tendon will glide easily, and that will help you for activity in daily living. flexor digitorum profundus that cause flexion of DIP, flexor digitorum superficialis that cause flexion of PIP. So first, tendon gliding exercise, straight your hand. Second, make a hook fist. So while making this hook fist, at that time maximum gliding occur between flexor digitorum profundus and flexor digitorum superficialis. This we can notice in this picture. So we have to hold this position for 2 to 3 seconds, and again we have to come in open hand position. Then we are going for full fist exercise. So again we have to straight the hand, make a fist, hold it for 2 to 3 seconds. It should be pain free. If patient is having pain, they have to stop this exercise. This making full fist that will help for maximum excursion of tendon in sheath over the flexor digitorum superficialis. Then intrinsic plus position or tabletop position. In this you have to slowly, first you kept your hand open, then you have to slowly bend your fingers forward. So here you guys can notice that our knuckles is knuckles, from knuckles to here finger is straight in L-set position, and we have to maintain again this for 2 to 3 seconds, then keep it straight. Then sublimis fist or straight fist that cause maximum excursion of flexor digitorum superficialis tendon in sheath. So same, we can hold it for 2 to 3 seconds, and again we can straight our hand. So these 5 tendon gliding positions that will help to relieve the symptoms in carpal tunnel syndromes, and that's why we are doing tendon gliding exercise. Now we are going to see operative management of carpal tunnel syndrome. First is maximum protection phase that will start at 0 to 2 week or 0 to 3 week. For immobilization, we have to give wrist splint in neutral or 15 degree of extension. So that will help the patient for relieving their symptoms. This is a very comfortable position for the patients. Bulky dressings for days, few days to a week, and then after we can apply compression splint at the wrist, and patient can wear compression glove. To reduce edema, we can elevate the hand and apply ice massage, and when bulky dressing is not there, we have to start active range of motion exercise, especially in extension, because if we are doing active exercise in flexion, so that may affect the median nerve and that may aggravate the symptoms, because this is recently operated and that cause aggravating the symptoms of the median nerve problem. So first we are going to start active extension exercise and passive flexion exercise. Then we can do full finger flexion extension exercise immediately after the surgery and after the removal of the bulky dressings. So we can emphasize on activity in daily living after 2 to 3 weeks. We are doing range of motion exercise to restore the function of our finger and the wrist. And the tendon gliding exercise, this is the example of range of motion exercise also. Especially typical tendon gliding exercise like hook fist, that will, earlier we have already seen how to bend the finger and everything, so that we can also apply for this operative management. We have to take care, or we can tell it the precaution. So we have to start active exercise for extension, then passive flexion exercise. Isometric exercise after 2 to 3 weeks, because that may increase symptoms in the median nerve distribution. Avoid activities that is cause median nerve irritation, like repetitive gripping activities, tip to tip grip, that kind of activities we have to avoid. Let's see moderate protection phase that start at 3 to 4 week, and return to functional phase that will start at 6 to 12 week. Exercise for moderate protection phase, we have to start active range of motion for wrist extension, radial deviation, ulnar deviation, finger and thumb exercise with wrist in neutral or extension. Apply soft tissue massage over the thinner aspects of your wrist. Then we have to start combined motion of wrist active flexion, pronation of a forearm and supination of your forearm, elbow extension, like this. We can start at 3 to 5 weeks. We can start dynamic strengthening exercise at 4 weeks. We have to take care for strengthening exercise because before 4 weeks if we are starting, that may affect the healing process also. Then we have to do some therapeutic putty exercise that is available in different colors, so that will give you the resistance. Wrist and finger stretching exercise, and after that we can tell that patient for 6 to 12 week return to functional training, and in that specifically we have to give ergonomic modification. For example, if they are using computer, so how to use the mouse while using the computer, like this way we have to prescribe some exercise ergonomic modification for them. Desensitization exercise, we have to start from light to deep touch exercise. Deep touch desensitizes exercise, use different texture with that. We are using this desensitization exercise to normalize the sensation because after the surgery it may affect your thumb, index finger, middle finger and this half of the ring finger. So we are giving some desensitization exercise over here, so that will improve your sensation and keep that will normalize the sensation. We have to take care, or we have to take precaution, like avoid wrist flexion gripping exercise up to 4 to 6 weeks. Rheumatoid arthritis, swan neck deformity management. We have to do immobilization, splinting for distal interphalangeal joint in full extension, as MCP and DIP are going for flexion. So we have to keep DIP in extension position with or without stating digital splinting. Exercise, we can start active range of motion exercise for proximal interphalangeal joint and distal interphalangeal joint after 2 weeks of post-operatively, and stabilize the proximal interphalangeal joint with slight flexion if exercising for distal interphalangeal joint in extension. Then we have to take care for precautions, like limit the proximal interphalangeal joint in extension of 10 degree while doing exercise. Avoid stretching of volar side of the capsule and avoid extreme distal interphalangeal joint flexion. Let's see rheumatoid arthritis, Boutonniere deformity management. Immobilization, maintain immobilization of your proximal interphalangeal joint in extension. Here we can notice that the proximal distal interphalangeal joint is hyperextended, and after the surgery we have to do exercise and wear the splint and remove intermittently for exercise. First we have to start exercise after 3 to 6 weeks post-operatively. We can start with active assisted range of motion of proximal interphalangeal joint flexion and 10 to 14 days, and we have to stabilize the metacarpophalangeal joint during exercise. If we are doing early distal interphalangeal joint flexion, then we have to maintain oblique retinacular strength ligament. Range of motion emphasis, especially for proximal interphalangeal joint extension and distal interphalangeal joint in flexion, because deformity is hyperextension of DIP, so we are going to maintain in flexion position. Precaution for Boutonniere deformity: avoid hyperextension of distal interphalangeal joint. To correct the central slip, this is central slip repair, so to correct the central slip repair and repair the extension mechanism with the help of surgery, so avoid stretching and resisted exercise of proximal interphalangeal joint for PIP extension mechanism up to 6 to 12 weeks post-operatively. Rheumatoid arthritis generalized management, physiotherapy management for pain. Heat is contraindicated in acute state. because that will stimulate collagenous activity within the joint, and further that will cause the distraction. So this is the precaution. After that we can apply the heat, and the splint we can apply for the correction of the deformity. Exercise, we have to start range of motion for activity in daily living. If intrinsic muscles are tight, that may pull extensor tendon and hyperextension of your proximal interphalangeal joint. Example, swan neck deformity. So for extensibility exercise for intrinsic muscles, and we have to do stretching exercise for that. Tendon gliding exercise, we have already explained why it is helpful. And if patient is having ulnar drift, so strengthen the radial deviator, so that will prevent the ulnar drift. Tenosynovitis, tendinitis or Quevain's disease management. Patient presentation in Quevain's disease: pain on the radial side of the wrist and anatomical snuff box. Tendinitis, pain in affected muscles tendon. Common symptoms we can notice for this patient like warmness and tender on touch. Pain increase with repetitive gripping activities of the hand. So let's learn physiotherapeutic management. Immobilization, use splint according to the tendon involvement. To control inflammation, apply antiphorosis, phorosis or ice. Patient education, teach activity modification, for example avoid gripping and heavy weight lifting. Exercise and mobilization, apply cross fiber massage in tendon elongation position, and teach tendon gliding exercise, functional activities to return for activity, and dynamic strengthening exercise for affected area. And mobilization we can apply according to the restriction. Tendon rupture management, flexor tendon rupture or extensor tendon rupture. Flexor tendon rupture is most common. For flexor tendon rupture, immobilization for 3 to 4 weeks with protective splint, especially digit is in flexion position, and rubber band traction is applied for maintain the IP joint in 30 to 50 degree of passive flexion. For acute phase of flexor tendon rupture, we have to control edema, and we have to wait for wound healing. So passive range of motion exercise we can apply in flexion, and resisted extension with splint. Let's learn active range of motion exercise for flexion tendon repair. We have to start flexion exercise first, then extension exercise at 4th week, and we can start active range of motion exercise after that. Especially at the 4th week we can start active range of motion exercise. Resisted range of motion exercise, once we have achieved full range of motion without any pain, we can start resisted range of motion exercise. Let's learn extensor tendon repair management. So extensor tendon repair, that may be distal tendon repair or proximal tendon repair. If it is distal tendon repair, so we have to immobilize the distal interphalangeal joint in neutral position for 6 to 8 weeks, and we have to immobilize the digits in extension for 4 weeks. So this immobilization period is very helpful for prescribing the exercise. So just remember, for flexion 3 to 4 weeks, for extension tendon repair distal 6 to 8 weeks, proximal 4 weeks. And acute phase management for extension tendon repair, we have to control edema, wound healing management, and can start passive range of motion exercise. Active range of motion exercise for distal tendon repair, we can start active range of motion exercise at 6 to 8 weeks with active extension, then active flexion. Proximal tendon repair exercise, we have to start with passive range of motion in flexion and MCP in extension. Then gradually full range of active range of motion exercise start at 6 weeks for proximal tendon repair. Resisted range of motion is we can do after once range of motion active range of motion is full, then we can go for resisted range of motion exercise. Now we are going to see ulnar collateral ligament sprain management. It may be grade 1, 2 or grade 3 sprain. So if it is grade 1, 2 sprain, we can directly immobilize with thumb spica cast for 3 weeks. Then gently start active range of motion exercise for flexion and extension after 3 weeks. Strength training we can start at 8 week. Especially we can take the precaution like we don't need to apply any stress on abduction, like if we are applying abductor stress on the thumb, so that may aggravate the symptoms. So avoid stress up to 2 to 6 week. If it is grade 3 tear, so that may displaced injury, so bony eversion injury will be there, so that is treated with the help of surgery. Thumb spica splint for 3 weeks and additional 2 weeks for splinting is needed for this kind of a injury. Let's learn Dupuytren's contracture or Palmar fasciitis management. Immobilization: initially splint is positioned to provide metacarpophalangeal joint flexion and 10 to 20 degree is of proximal interphalangeal joint extension. Range of motion exercise: we can start passive exercise, active assisted, and active exercise started immediately. Let's learn mallet finger management. So for mallet finger management, we have to do immobilization with the DIP in extension for 6 weeks. Range of motion exercise: we can start proximal interphalangeal joint range of motion exercise, MCP range, active range of motion exercise, and then after we can start distal interphalangeal joint exercise. We have to tell patient to apply 9 splint to maintain DIP in extension, and that we can discontinue by the end of 9 week. We can start resisted range of motion exercise after 8 week or at the 8 week. Let's learn trigger finger management. We have to apply splinting, especially at night. This is the splint for trigger finger, so that will keep your finger in extension. And then we can prescribe flexibility exercise of the digits without any aggravating condition. Surgical management: first week we have to start active assisted range of motion of MCP, PIP and DIP. By 2 to 3 weeks we have to progress for active range of motion to active exercise for all 3 joints, and after 3 weeks we can start resisted range of motion exercise. Let's learn triangular fibrocartilage complex physiotherapeutic management. First we are going to see conservative management. So for conservative management, we can apply long arm cast or splint that is fitted with elbow 90 degree flexion, and we have to keep forearm especially in 90 degree position, wrist in ulnar deviation and extension for 6 weeks. After removal of the cast, we can start active assisted range of motion exercise, especially in flexion, extension. Then we have to progress for pronation, supination, radial deviation and ulnar deviation. Then we can progress for strengthening exercise. Let's see colle fracture and Smith fracture management. Immobilization is 5 to 8 weeks for both. In colle fracture, dinner fork is very common, deformity is common. In Smith's fracture, garden spade deformity is common. This is happened due to fall on outstretched hand. This Smith fracture happened due to flexion, fall on the hand, or flexion while falling, patient hand is in flexion. Exercise: we can start passive range of motion exercise first in the first week, and especially range of motion exercise for the shoulder and tendon gliding exercise. Then after range of motion for flexion, extension, radial and ulnar deviation. Therapeutic putty for grip strengthening. If we are not providing good exercise, so patient's hand limitation is there, so supination is limited. Mobilization we can start after 6 to 8 weeks. And for Smith's fracture, we can start flexibility exercise and range of motion training. Let's see scaphoid fracture management. So for scaphoid fracture, we have to immobilize the wrist with thumb spica cast for 4 to 8 weeks. most common complication is avascular necrosis, because radial here you can see that the radial artery is going, so that is affected. We can start passive range of motion exercise after 2 week, active assisted range of motion exercise um, after that, and then we can follow active range of motion of flexion, extension, supination, and pronation. Let's see boxer's fracture management. We can immobilize patient for 2 to 4 weeks, and physiotherapeutic management we have to do for like reduce the edema, flexibility exercise, and strengthening exercise. Let's see mobilization of distal radio-Ulnar joint. So for that, concave move on convex. Concave surface is ulnar notch of radius, and convex surface is convex head of ulna. Glides for supination. Here we can notice that for supination we can give dorsal glide, and for pronation we can give volar glide. Patient position in sitting. So we have to stabilize distal ulna, and we have to mobilize distal radius. Let's learn radiocarpal joint flexion and extension glide. So for that, convex surface move on concave surface. Convex surface is your proximal carpal bone, and the concave is radius. For flexion, we will give a dorsal glide. So first distraction, then just give dorsal vertical glide. So then it will improve your flexion, and the volar direction glide, that will improve your extension. So patient should be in sitting position with forearm supported on the table, and wrist should be over the edge of the table. Here for dorsal glide, you guys can notice that patient's hand was on supination position, and here it's in pronated position. Stabilize for stabilization, we have to stabilize the radius and ulna and mobilize the proximal carpal row. Now we are going to see ulnar glide, ulnar deviation and radial deviation improvement. So for that also, convex surface move on concave surface. So convex is proximal carpal, concave is radius. So if we want to improve ulnar deviation, radial deviation, so for that we have to give ulnar glide, so that will improve your radial deviation. And if we want to improve ulnar deviation, so we have to give radial glide. So patient should be in sitting position, forearm supported on the table with wrist over the edge of the table. We have to stabilize radius and ulna and mobilize distal carpal row. Let's learn intercarpal joint mobilization. So for that, concave move on convex surface. Concave is radius, convex is your proximal carpal, like scaphoid and lunate. So if we want to improve flexion, so for that we have to give volar glide. Patient position in sitting, we have to stabilize proximal bone. So with fingers I have stabilized scaphoid and lunate, and we have to mobilize the distal bone, so that is radius. So from them we can mobilize the distal bone. So for improving flexion, we can give volar glide. Same way for extension. Let's see here. So if we want to improve intercarpal joint extension, so for that, convex moves surface on concave. So concave is your ulnar notch of radius, and convex is your distal carpal row, like trapezium, trapezoid, capitate, and hamate. So for that, patient position is in sitting. We have to stabilize the proximal bone. So I have stabilized with the fingers, the lunate one, and we have to mobilize the distal carpal row. So we can notice that with the third finger, or with the middle finger on the line, your capitate will come. So I'm mobilizing the capitate and stabilizing the lunate. Okay, so that will improve your extension. Let's see biomechanics of thumb. We are going to see biomechanics of thumb again, because in the this biomechanics slide, anatomical slide, we have some typing mistakes. So for that, just for correction, I have included this biomechanics of thumb. For biomechanics of thumb, concave surface move on convex surface for flexion and extension. So here we can notice that our convex surface is trapezium. This is your thumb, this is your scaphoid. So this is your metacarpal bone. So metacarpal is, you guys can notice, this is concave. So here concave surface is moving on convex surface. So during, this is flexion, this is extension. So if patient is doing flexion, so metacarpal will roll and glide medially on trapezium. And for extension, metacarpal roll and glide distal, glide laterally on trapezium. Let's see carpometacarpal joint mobilization. So for that, concave surface move on convex surface for flexion and extension. So for that, concave surface is your metacarpal and convex surface is your trapezium. For this reason, I have included the biomechanics slide for the correction. So just have the reference of your anatomical slide. So for first thumb flexion and extension. For flexion, this is your flexion, this is your extension. So for flexion, we can give medial or ulnarward glide, and for extension, we can give radial or lateral glide. For carpometacarpal joint 2 to 5 flexion, we can give volar or anterior glide, and for extension, we can give dorsal or posterior glide. Okay. Patient position should be in sitting. Keep the hand in mid-prone position, or thumb should be in midway between flexion and extension. Here is mid-prone position. Thumb is between flexion and extension. And we have to stabilize the distal carpal, and we have to mobilize the proximal metacarpal. Here you guys can notice that proximal metacarpal is mobilized.
Thanks for watching, and for future videos don't forget to subscribe. If you have any doubts related to topics in physical therapy exams, please let me know in my comment section so I can make a series of the videos on that. Till that time, stay positive. Bye bye.